now. Thank you all for joining us today for Dr. Molly Kessler's talk, The Plural of Anecdotes is Data. A little bit about Dr. Kessler quickly. Dr. Molly Kessler is an associate professor and director of graduate studies in the Department of Writing Studies at the University of Minnesota, Twin Cities. From exploring how patients use online intervention tools to support their healthcare to investigating why and how physicians write stories to process the lived realities of providing healthcare in today's world, Dr. Kessler studies how people make meaning of their lived experiences within health, disability, and medicine. Most recently, her book, Stigma Stories, Rhetoric, Chronic Illness, and Lived Experience, examines how how the stories popular media, patients, healthcare providers, and majority health institutions tell publicly and privately about chronic and gastrointestinal conditions have a profound power in perpetuating and resisting health-related stigma. Dr. Kessler, thank you for joining us today and for sharing your expertise. We're excited to have you as part of this speaker series. The floor is now yours.
Thank you so much. Good afternoon, everyone, and thank you for that introduction, Kirk. As Kirk said, I am Molly Kessler. I use she, her pronouns, and I'm currently an associate professor here at the University of Minnesota Twin Cities in the Department of Writing Studies. Before I dive into my talk today, I want to start by thanking Kirk and the Center for Health and Medical Communication at Louisiana Tech, as well as the Eunice C. Williamson Endowment in Technical Communication and the Southwest chapter of the American Medical Writers Association for inviting me to speak and for sponsoring and hosting this series. I'm very delighted to be here with you and be in conversation and community with you all. I have shared a version of this talk with Kirk for anyone who might want access to the transcript and slides. There should be a link available to a PDF version. I will note that I have, of course, continued to tinker with it since I shared that copy, so that you'll notice some differences, but most of what's there should be pretty consistent with the talk I'll deliver today. So let's dive on in. When Kirk first invited me to speak as part of this series, he suggested that I think of this talk as an opportunity to think and talk about the research I've been working on lately that most excites or interests me. I recently wrapped a near decade-long investigation into the lived experiences and rhetorical practices of folks living with chronic gastrointestinal or GI conditions and ostomies. That work culminated in a book called Stigma Stories that thought through the role of stories in establishing, circulating, and also resisting stigma. In the wake of that work, I've continued to read and think a lot about stories. Their role in medicine and health, who gets to tell the stories, how stories gain traction and are circulated, and how different fields engage with stories. This long-standing phrase, the plural of anecdote is not data, has always sort of lingered in the back of my mind as I've been doing this work. Are anecdotes data? Why should or shouldn't they be considered data? And this phrase is really interesting to me. It sort of has an odd history. Some argue that it's actually a misquote, and the person who has been attributed with this quote actually meant to say the opposite, and say the plural of anecdote is data. And it's credited to a handful of people if you do some digging. It's got a messy history. Regardless, this phrase has come to sort of stand in for a culture or logic that questions the value of anecdotes or stories as useful or valid data. This phrase calls into question the study of stories, how to do it, quote unquote, rigorously, and how to attend to the complexity of the many stories about health and medicine that are being told every day in many different contexts and by many different people. To be honest, I've had different kinds of relationships with thinking through if anecdotes are or are not data. I find myself frustrated by what feels like an implicit dismissal of patients, the humanities, and anything but evidence-based medicine tied up in the idea that anecdotes are not data. At the same time, or in other instances, I find myself somewhat hesitantly resonating with the idea that the plural of anecdote is not data. For example, when I see influencers on Instagram talk about a supplement they take and then suggest taking that supplement to thousands of followers based on their single experience, I start to empathize with maybe the spirit behind this phrase. So because of these mixed feelings, I find myself thinking a lot about the role of narratives in and about health and medicine, why they matter, where the limits of their value lie, how to better communicate with and about stories across disciplinary and paradigmatic divides. And so this talk is going to focus on these questions and tensions. Okay, so these graphics get at some of the underlying logic of the phrase, the plural of anecdote is not data. The one-pane comic on the left side of the screen is entitled How to Make a Scientist's Head Explode. The comic shows an angry-looking person saying anecdotal evidence isn't valid, to which another more surprised or perhaps upset-looking person says, yes, it is. I once used an anecdote as evidence, and later it turned out I was right. The screenshot on the right is from Twitter or X or whatever it's being called these days, from Dr. Jonathan Stee or Stea, I'm not sure, who is a clinical psychologist, faculty member at the University of Calgary, and founder of Science Up First, an initiative with the goal of battling scientific misinformation. This post reads, "The plural of anecdote is misinformation," so taking it even a step further. Problems with anecdotal medical evidence include a regression to mean, self-limiting illnesses, multiple treatments, reporting bias, confirmation bias, vague outcome measures, placebo, memory fallibility. It's a long list. While I don't necessarily disagree entirely with the diagnosis here of the problems that can emerge with anecdotal evidence, I can't help but observe that these issues are not unique to stories. But this tweet and comic do point to a larger tension I'm interested in exploring. How do we simultaneously examine stories as data and for the data they provide while attending to issues and complexities of anecdotal evidence? How do we balance these concerns about anecdotal evidence with the important role stories play for many stakeholders in health and medicine? If we take as true that stories are important, how do we help demonstrate that value in a way that is consistent with the values and approaches to stories outside of biomedicine, including fields like rhetoric and writing studies, or communication, health humanities, narrative medicine, and others, and social sciences as well, and in a way that allows us to share the insights of this research in a way that's compelling to the folks who might need to hear these stories and what we can learn from them, like healthcare providers and experts in biomedicine. So quickly, before we go any further, I just wanted to have a note on terms here. So these terms are frequently used interchangeably. Some scholars work, so the terms I'm talking about here are anecdote, story, and narrative. Some scholars work to distinguish them from one another, and those arguments really depend on context. For my purposes today, I'm not going to make a meaningful distinction between these three terms. I know that that's sort of comes with benefits and risks, but I just want to say I'm using them somewhat interchangeably and invite you to sort of suspend your sense of the distinction between these terms as we move through the talk today. Okay, so there are many different disciplinary traditions interested in stories, and thus many theoretical and methodological approaches to studying stories within and about health and medicine. Scholars across several disciplines have been interested in narrative, both generally and specifically for the role they play in human experience. For example, cognitive scientists have been examining the role that narratives play in shaping our understanding of the world and our ability to engage with each other. Literary scholars have been examining and dissecting narratives to understand the literary dimensions within stories. And closest to home for me, rhetoricians have studied the persuasive dimensions of stories from micro levels like semantic moves to macro levels like public functions and public circulation of stories. Among these, narrative medicine is perhaps one of, if not the most well-known field for studying stories in health and medicine. Narrative medicine's proximity to medicine, or perhaps more accurately, that narrative medicine operates from within medicine, that is, MDs sort of theorizing and building the field, has allowed it to especially gain traction as a predominant approach to thinking about and through stories within medicine. Thus, I think it's helpful to consider what narrative medicine is and does as sort of a starting place for grappling with the fraught role of stories or anecdotes in the context of biomedical research and healthcare practice. Okay, so narrative medicine is defined by Rita Sharon, who's widely considered a founder of the field, in the following way. Narrative medicine provides, quote, the competence to recognize, absorb, interpret, and be moved by stories of illness. And it emerged as a field to challenge a reductionist, fragmented medicine that holds little regard for the singular aspects of a patient's life, and to protest the social injustice of a global healthcare system that countenances tremendous health disparities and discriminatory policies and practices. With these goals and context, narrative medicine is really focused on close reading of stories that gives way to a close listening in clinical encounters or patient-provider contexts. And narrative medicine focuses on content of stories, literary analysis, empathetic comprehension, nonverbal communication, experiences of patients and physicians, as well as the creative ability to tell new narratives. Narrative medicine in many ways aims to respond to what has been identified as a division between art and medicine, and a lack of humanistic values within evidence-based medicine and the practice of healthcare. With this focus on close reading, narrative medicine tends to take a narrative detective approach, as Solomon, who's a philosopher of science, calls it, in which the researcher or analyst's job is to focus on frame, form, time, plot, and desire within a story to yield information about temporality, singularity, causality, intersubjectivity, and ethicality. Similarly, in a chapter from a methods handbook in Comp Studies, Yamasaki and collaborators provide a framework for conducting narrative medicine research that includes questions about character, setting, plot, storytelling devices, and activities, consequences, and purposes of narratives. I provide this overview of narrative medicine because I think it can help contextualize the kind of work that often comes to mind when we think about studying stories in and about medicine, particularly in interdisciplinary contexts. Specifically, narrative medicine is perhaps the most dominant or most recognizable way of studying stories, particularly for folks in medicine. Two, narrative medicine has emerged in response and work to counter the plural of anecdote is not data problem. Yet, narrative medicine is not the only way we can think about and study stories, and I'd like to make a case today for what a rhetorical approach to studies has to offer. To be clear, this is not to criticize or suggest narrative medicine is not valuable. I think rhetorical approaches to stories add to the important work narrative does and to our academic understanding of the role of stories in health and medicine. However, as a rhetorician and technical communication specialist, I share with narrative medicine an important commitment to stories, but I often don't see much overlap with the work of narrative medicine and the kinds of research questions and approaches I take when I'm thinking about stories, and I see my colleagues in rhetoric taking when they're thinking about stories. Thus, today, I'm going to think about and think through what rhetorical approaches to story can and are doing to add, extend, and perhaps complicate narrative medicine. Specifically, while narrative medicine tends to view the clinical encounter through the lens of story, often focusing on individual anecdotes, studied through that narrative detective approach with close reading and listening for various elements in the stories, I'm more interested in how stories shape a range of health and medical experiences or encounters. I'm also interested in asking what stories tell us about the practice of medicine and the experience of that practice for patients. How do micro-level rhetorical features or meaning-making features of a story shape the rhetorical purpose and effect of that story? What rhetorical complexities are present in these stories regarding expertise and experience and knowledge? How are we leveraging those pieces? How does ethos affect a story? How are different kinds of stories received by audiences, intended or not, and circulated within the public sphere? And ultimately, how do all these pieces fit together to shape a discourse, to shape discourses about different illnesses, embodied experiences, medical knowledge, and healthcare practice? These are the kinds of questions that examining the characters, plots, and scenes of stories might not get at, and not necessarily that these are more important questions. There's just different questions that can provide different kinds of data and thus different claims and knowledge that we might contribute across disciplinary fields and experts. Okay, so to help illustrate the kind of approach or thinking with stories that I'm advocating for, I'd like to walk through some examples from a variety of projects that might seem semi-unrelated, all that engage with stories in one way or another. With each of these exemplar stories, I aim to highlight how rhetorical research into stories has the potential to be both useful and applied, as Siegel might describe. So first, I'll take a look at how stories individually and collectively can participate in stigmatization, and also how public stories shape the stories and lived experiences of individuals. Then we'll take a look at some stories about do-it-yourself fecal microbiota transplants, for how those stories raise questions about evidence, expertise, and experience. And finally, we'll look at some excerpts from a recent collaborative project I've been working on that explores published physicians and other healthcare providers' narratives, specifically about COVID, for how those stories form a rhetorical archive of sorts that allows for a systematic analysis of stories. All right, let's dive in. So first, stigma stories and narrative regulation. Okay. In Stigma Stories, my book, is also a concept I use. So I get that can be confusing. As I briefly mentioned earlier, I focus on how stories are imbricated in the emergence, circulation, and resistance of stigma. In that research, I focus on several high-profile or high-exposure stories. So those stories that are told and circulated in public spheres to broad public audiences through media platforms like ads, commercials, social media, TV shows, etc. I argue that these stories feature lived experiences and practices with chronic gastrointestinal or GI conditions and ostomies that enable the stories to have a stigmatizing effect within the public sphere. The negative experiences featured in these stories both rely on and perpetuate stigma. And very importantly, these stories represent real lived experiences of individuals that should be listened to and understood. So let's take a look at a few examples to talk about the rhetorical features that we see in some of these stories. Okay, so this is Julia. She's pictured on the screen, a middle-aged Black woman. In the photo, she's sitting on what looks like a bed or in a bedroom, holding an ostomy pouch away from her body towards the camera. She is one of 30 plus former smokers who serve as representative for the Center for Disease Control and Prevention's Tips from Former Smokers campaign, which is an anti-smoking effort aiming to build public awareness, encourage smokers to quit, and encourage smokers to not smoke around others by featuring former smokers who are real people with real stories who are living with serious long-term health effects from smoking and secondhand smoke exposure. So in Julia's participation in this campaign, she tells her story publicly in a TV ad, and it goes like this. I smoked and I got colon cancer. I had chemo and 2 surgeries, but what I hated most was the colostomy bag. That's where they reroute your intestines so you have bowel movements that go into a bag through a hole in your stomach. You go wherever it goes, you have no control. If it comes loose, it smells. I had to wear it for a whole year. I was at home the majority of the time because I was scared it would come loose and it would smell, and I didn't want to be around anyone. I was really kind of stuck at home. My tip is to get over being squeamish. You're going to be emptying your bag 6 times a day. Julia's story, is positioned as part of the CDC's anti-smoking campaign, aims to convince viewers to quit or avoid smoking because receiving an ostomy could be a consequence, an incredibly constraining and undesirable consequence. For context, just to reiterate, Julia shares it here, but not everyone knows. So ostomies are used when all or part of the GI tract need to be removed, in which case the end of the large or sometimes small intestine is made external through an opening on the abdomen, which allows the individual to excrete waste through that opening. Essentially, Julia with the CDC tells the story of life with the ostomy pouch here as a negative one. Julia shares that her life with her ostomy was leaky, smelly, and isolating. And through this story, the CDC seems to hope to scare viewers into quitting or not smoking through the fear of potentially having to get an ostomy too. I want to be clear here about 2 things. First, the CDC has explicitly stated that they leveraged scare tactics in this campaign, that was their explicit rhetorical goal. They cite various studies that have tested the role of fear in health stories for enacting desired change, and they've also conducted their own research to test the impacts of this campaign. And their research has found that the campaign's effective. According to their data, this campaign has been successful in convincing lots of people to attempt to quit smoking. Secondly, I want to be clear that I believe Julia in her story. I don't think there's much to be gained by questioning the truth of Julia's story or the truth of most health-related stories. I don't think it's Julia's explicit intention to stigmatize ostomies or perpetuate harm in the ostomy or chronic GI communities. Instead of trying to decide if we believe people's stories or find them to be true, I think it's more productive to focus on whether or not we should do something based on these stories and to consider what is at stake in the persuasion. A rhetorical approach to stories here allows me to consider what larger rhetorical effect the story has, what is it accomplishing within public contexts and discourses related to ostomies. It allows me to gain insight into the kinds of stories patients and publics might be hearing about ostomies, which is important for considering the meaning of ostomies more generally. Or put another way, Julia's stories and others like it, we'll look at a few, can help us understand the stories surrounding ostomies or other illnesses and conditions, and to contextualize those stories with other kinds of information like clinical recommendations and biomedical data. This story also points to insights about the CDC and whose bodies, stories, and lived experiences they're concerned with, or not. I couldn't find any evidence that the CDC considered how these scare tactics in the TIPS campaign might affect people who are already living with ostomies for smoking-related reasons, or far more likely for various reasons that the patients had no control over. Okay, alongside Julia's story, I want to share that her story was not an isolated rhetorical event. There are lots of other public stories that sort of take similar rhetorical moves as Julia's story did. We're going to look at one additional one here. So indeed, the plural of anecdote it very much is data when we place Julia's story among other highly visible public stories. There are many other public ostomy stories that I examined as part of this research, including some storylines from the popular medical drama Grey's Anatomy. The quotes here come from a multi-episode storyline featuring a character named Clara who had a double leg amputation due to a boating accident. During that accident, Clara was in water and came into contact with some contaminants in the water. So after her amputation, she ends up developing an infection that manifests as an abscess, sort of a pocket of infection in her GI tract that needs surgical intervention. But having undergone a bunch of other surgeries already, Clara's character refuses. She doesn't want GI surgery, and she begs her care team for an alternative. She asks about other options for a drug treatment, but is told none of those will suffice. Ultimately, she asks one of the physicians on her care team what the worst case scenario would be if she doesn't pursue the recommended surgery, which they're recommending she does immediately. To which the physician responds, well, worst case is that we'd have to take out part of your colon and give you a colostomy bag. Clara responds visibly with disgust at the thought of needing what she calls a poo bag and continues to refuse the surgery. The next scene is especially interesting. So the doctor who says this about the worst case leaves the room, and a little while later is confronted by their attending physician who reprimands this physician for serving Clara a death sentence, direct quote, because they mentioned a colostomy bag. Like Julia's story, Clara's story relies on fear and a very particular and singular sense of ostomy experience and the stigmatization of ostomies. As these stories hopefully are starting to demonstrate, and in my assessment, the public ostomy stories are pretty consistent. They have feature similar rhetorical strategies, whether intentional or not, that rely on and reinforce stigma. Individually and collectively, they suggest a very specific and consistent ostomy story that's negative and undesirable. And they do so through some recurring rhetorical dimensions, some of which you see in these stories and some which are sort of explicated in other examples. But these public ostomy stories, the ones that are really high profile and circulating in these really broad public discourse spaces, position ostomies as worst case scenarios. It's language that comes up repeatedly in these stories. They focus on experiences with leaking ostomies and with feces. They feature a lot of rhetorical omissions or the persuasive leaving out of important information or context that might give a richer picture to these chronic GI conditions and ostomies. They use scare tactics to motivate actions. Unrelated to ostomies, often quit smoking, avoid participating in a gang is another example that I talk about of a police department in Cincinnati talking about not participating in gang violence because you could get shot and end up with an ostomy. And many of these stories rely on disability stereotypes. Importantly, a rhetorical approach to stories, one that I'm advocating for, can also help put these kinds of public stories in context. A rhetorical approach invites us to think about how these stories were received by audiences who were intended or otherwise, what other stories might be told, so what stories might be missing when we get a sort of singular picture, and how these stories function and create meaning as they circulate in the world. I didn't have to look far to find some reactions to the stories we just looked at, particularly Julia's and the Tips from Former Smokers campaign, but similar reactions to the other stories as well. Many in the ostomy and chronic GI communities responded to Julia and the CDC with total outrage, arguing that Julia's negative experience and using ostomies as a scare tactic not only is inaccurate to the way many people experience their ostomies, but is particularly harmful and representative of the stigma that surrounds these kinds of conditions. People drafted petitions, thousands of people signed these petitions, and people flooded the CDC social media accounts, eventually resulting in the CDC taking down and revising Julia's video. Julia still has a video on the campaign website. It still talks about ostomies, but in a much more muted way. The language that I pulled, I archived before this all happened. And in a letter from the United Ostomy Association of America and the Crohn's and Colitis Foundation of America wrote, "The situation here is especially serious precisely because the CDC, a trusted source of important medical information, has spread the message. We know that your ads are undermining what we have done to empower, educate, and reduce the stigma of ostomy surgery." While Julia depicted her ostomy as negative and constraining, many in the IBD and ostomy communities, chronic GI communities and ostomy communities, argue that ostomies are actually life-saving and can empower people to live, quote, normal lives. So in digging further and conducting some story-focused interviews with several folks living with ostomies and chronic GI conditions, I found that not only do many patients find their ostomies empowering, positive, life-saving, they actually experience these technologies and these surgeries as part of their bodies and identities, so much so that they call themselves ostomates. The photos on this slide sort of represent this more positive story regarding ostomy experience. So on the left side of the screen here is Gut Girl, a self-proclaimed superhero via her ostomy. So her superhero attire includes a cape and a headpiece and an ostomy. In the middle, there's a screenshot of a tweet from Vicky Mulholland, who writes, "My stoma makes me superwoman, has given me my life back and makes me awesome." And finally, the third picture on the right shows several individuals with matching blue shirts folded up to reveal their abdomens, each of which include an ostomy or ostomy scars. This far right image includes several of the individuals I've spoken with through this research who share celebratory and empowering ostomy stories that look much different than Julia's. I want to recognize here that there is a superscript narrative running through some of the stories, particularly on this slide, that can be really problematic for many folks living with disabilities and chronic conditions. I'm not suggesting that a superscript narrative does not come without some of these problems, but what I'm trying to show here is that there is a diverse range of ostomy stories and experiences, ranging from ones like Julia's to ones like Vicky Mulholland's, and at every point in between in that spectrum. And we need to work to account for this diversity and multiplicity as we study stories in health and medicine. Importantly, the results of this research suggest that Julia's case is representative of a large theme within the chronic and GI ostomy communities and public discourse. And this research suggests there are diverging ostomy stories. And some, like Julia's and those on TV, have a much larger public audience and potentially a much larger rhetorical effect. And then have a much broader potential impact in shaping the meaning of ostomies and chronic GI conditions. Examining these stories allows researchers like me to understand what kinds of stories patients might be bringing into their own lives and into clinical encounters in their healthcare. For instance, folks might see Julia's commercial and avoid life-saving surgery to receive an ostomy, or Clara's TV storyline and refuse ostomy surgery. This claim is, of course, speculative. I don't have evidence. I haven't done an RCT to look at the impact of these stories, but the point is that there's value in a rhetorical approach and looking at these kinds of stories to give context to how people are making meaning of these illnesses and conditions and how that meaning might impact their clinical encounters in healthcare. Furthermore, these stories say something essential about narratives in health and medicine more generally, about whose stories get told and whose do not or cannot. Judy Siegel refers to this as narrative hegemony, and philosopher Miriam Solomon has called this narrative regulation. What both of these terms refer to is that the power of widely circulated and repeated stories in the public sphere that suggest a single experience for all folks with a particular health condition or illness. Siegel, along with Barbara Ehrenreich, have both looked at the problems with the narrative hegemony of positive breast cancer narratives, particularly for women who don't have positive experiences with breast cancer. And I've built on this work in the context of chronic GI and ostomies to demonstrate that there are diversity of stories about ostomy experience, but the negative ones tend to get the most traction and circulation in the public sphere. Collectively, this work has argued that stories in and about medicine provide templates for our own individual lived experiences, and not only shape what we might come to expect when we have these conditions, but can present significant challenges when our own stories and experiences are unexpected or in conflict with these dominant stories. As Siegel writes, each of us, when we face a diagnosis of serious illness, need to get oriented to the new place in which we find ourselves. The stories we might tell of the experience, if we wish to tell a story at all, do need to be honored, even if, especially if, they're the ones no one really expects to hear. And as Solomon explains, the belief that narratives are singular gets in the way of discovering and acknowledging that narratives often have structural similarities with one another. And this belief often prevents us from seeing that these structural similarities can serve various purposes, including political ones. Rhetorical approaches to stories are primed to understand the complexity and multiplicity of stories, as Siegel work so compellingly demonstrates. And rhetorical approaches to stories can accomplish the work that Solomon's calling for here by examining the structural similarities and differences across stories, as I've been doing with stigma stories, to see how multiple stories and those similarities and differences can serve various purposes based on the means of persuasion within these stories. The next example we'll look at will demonstrate some of the risks of engaging with singular narratives in addition to the ones we've just been looking at. So let's talk about FMT. Okay, the second example focuses on a story shared through an online article in Undark magazine. I'll provide some more context about the story in a second, but You can find lots of these stories online. I've pulled one out that I think represents a discourse that you can find lots of examples of, a lot of data points of online, of people talking about how they do their own fecal microbiota transplants. So in this story, the author, whose name is Susan, shares her personal experience with do-it-yourself DIY fecal microbiota transplants, or FMT. FMT, as the name suggests, refer to transplanting fecal matter from a healthy individual to an ill person with the goal of adding good or desirable microbes into the gut of the sick person to cure or treat an illness. For instance, C. difficile, or C. diff, is a bacterial infection that affects the large intestine. The symptoms of C. diff can be really severe and deadly if gone untreated, and C. diff can be very treatment resistant. Antibiotics are the primary mode of treatment, but often only provide short-term relief. And C. diff frequently recurs, and these recurrences tend to be even more resistant to antibiotic treatment. Thus, FMT has emerged as a potential treatment for antibiotic-resistant or recurring C. diff cases. However, FMT has a complex regulatory relationship with the FDA, in part because the FDA has struggled to determine how to classify therapeutic fecal matter and thus has struggled to regulate it. In short, FMT is only FDA approved in severe C. diff cases and in some circumstances off-label as compassionate care. It's pretty difficult to receive FMT through a healthcare provider. I have some lived experience in this area, having had recurrent C. diff. And this sort of difficulty in getting FMT has led to an entire online community and industry for do-it-yourself fecal transplants. So here's a story from Susan. Susan writes, "My last trip to the emergency room was a grim formality. The C. diff battle now raged beyond my colon. You might want to tell loved ones about your dire circumstances," my gastroenterologist said. It dawned on me that my doctor would sooner let me die than discuss a fecal transplant. That's when I decided to do the transplant myself. This was in the dark ages of fecal microbial transplantation, before the procedure became ingrained in the American psyche. Notably, this story is from 2018. But there were a handful of websites that offered advice on do-it-yourself fecal transplants. Some were more questionable than others. One dubiously suggested using pet feces for the donor sample. But even with an appropriate two-legged donor, the procedure would carry risks of infection and the possibility of other adverse outcomes. Excuse me. My friends cautioned me against going rogue with an extreme unapproved treatment, but to me, the gamble was worth taking. Having made this decision to pursue DIY FMT, Susan goes on to say, the New England Journal of Medicine offered some procedural clues. For instance, my ideal donor would have a microbe that was untainted by antibiotics. That ruled out Esteban, who's her partner, who had recently been administered antibiotics during an eye surgery. Ultimately, I turned to my 11-year-old daughter. She agreed to do it, and around 10 p.m. on a Tuesday, Esteban collected the sample. He dropped it into a blender, added saline, blended it, strained it, and poured the concoction into an enema bottle as I lay depleted on the floor. My gut drank up the infusion as if it were dying of thirst. My colon, after 5 months of near constant spasms, recovered in one transformative instant. Overnight, I went from having 30 bowel movements a day to having 1. For breakfast the next morning, I ate a quesadilla loaded with black beans, cheese, salsa, lettuce, and guacamole. I've had no recurrence of C. diff since. Alongside Susan's text from Susan's story here is an infographic on the screen that depicts the typical DIY FMT process that Susan followed. Just as a quick side note, DIY FMT has become commonplace enough that Adobe Stock has a free stock image of the process, and you're looking at it here. So this image shows a person and some microbial looking graphics with an intestine, and then there's like a poop looking emoji, a blender, a test tube, and then ultimately a medication looking bottle, all with the same brown liquid, sort of showing how to prepare fecal matter for a transplant. Okay, so now for some rhetorical context. It's important, I think, to note that Susan, the author and storyteller, is credited, the byline at the bottom of this story, as an MA in the science writing program at Johns Hopkins and as a fellow for the Council for the Advancement of Science Writing. She's not an MD, but she has credentials that likely give her more credibility than a random blogger or influencer. Additionally, this story is published on Undark, a nonprofit digital magazine that's sponsored by the Knight Foundation and a fellowship program at MIT. Indeed, who tells stories matters, and where stories are circulated is also important for the overall rhetorical potential and impact of the story. This story, I would argue, is potentially bolstered by the ethos of both the writer and the venue. A bit more context, it's important to remember that DIY FMT emerged at least partially in response to the lack of options for non-DIY FMT due to FDA regulation and the lack of randomized controlled trial and safety data around DIY or around FMT more generally. On one hand, patients are seeking access to this treatment through DIY options because they literally can't get access elsewhere. On the other hand, patients literally can't get access elsewhere because the FDA hasn't approved FMT for broader use. Dr. Nandi, whose quote I have on the screen now, is a very well-known and respected gastroenterologist. Patients love him. He is well involved in advocacy organization and is a super highly sought after clinical provider as well as researcher in the GI field. And he's quoted in an online article about the risks of DIY FMT saying, "When it comes to the health of your intestine, how much faith do you want to place on anecdotal experience from online DIYers for non-established indications and without validated patient safety data?" It's also worth noting that the current standards for FDA-approved FMT result in only about 3% of donated samples being considered viable because they have such stringent criteria for ensuring samples are safe. Dr. Nandi is getting at the potential risks of anecdotal evidence here, the risks that potentially other approaches to studying stories might not account for when exclusively focusing just on Susan's story or another individual's story. Dr. Nandi is inviting readers to place stories like Susan's as data that can and should be put in conversation with other forms of data, such as biomedical data or the lack thereof. Rhetorical approaches to stories are primed to do this work. This quick DIY FMT example also demonstrates several key insights from a rhetorical engagement with stories. First, this case highlights that stories can and should be placed within rhetorical contexts, including public discourse, similar to how I demonstrated with, or tried to demonstrate with stigma stories, but also in triangulatory contexts, which is a term I made up. That is, stories as data can be put in conversation and should be put in conversation in context with other forms of data. And oftentimes, this allows for richer engagement and understanding of these stories. The risk here, or one of the main risks, is that biomedical data becomes privileged always over anecdotal data. But I think that this risk can be mitigated, and at least in part by having rhetoricians conducting this research, or as part of collaborative teams thinking through these stories, as we're trained to carefully weigh who and what is being privileged within a discourse. As Janelle Johnson puts it, rhetoric is the study of power and power in motion. Secondly, the stakes of stories are important. DIY FMT stories and other stories that explicitly conflict with biomedical recommendations can highlight the risk of some public stories. DIY FMT gone wrong can and has killed people. Stigma stories can prevent individuals from undergoing important, sometimes life-saving surgeries. The stakes and risks of these stories can be really high. In contrast, stories from Instagrammers or TikTok people convincing you to drink something like electrolyte powder have very different stakes and risks. Rhetorical approaches to stories invite us to consider the stakes and risks of individual and collective stories and allow us to do so by considering the rhetorical goals and impacts of a story. Sometimes these goals are explicit. Buy this product, do DIY FMT, but sometimes they're less obvious, like in Julia's case, where an implicit sort of rhetorical impact of the story is that life with ostomies is terrible. If you accept that and you're persuaded by that, you might be convinced to quit smoking. DIY FMT stories also illustrate that experience, knowledge, and expertise are not the same or are not interchangeable. These stories also demonstrate the need to simultaneously attend to patient and embodied experience and knowledge alongside clinical and biomedical expertise, and to weigh these different dimensions carefully with and against each other. Lived experience can lead to knowledge. For example, an individual's lived experience leads to embodied knowledge about what it's like to live with a condition, and this is critical knowledge that absolutely should be taken seriously. However, as Kenny Fountain's work has shown, expertise in medicine relies on cognitive, embodied, practical learning that takes time to develop, as is true with lots of expertise. Exploring stories throws the differences in relationships between knowledge, expertise, and experience into view, and in concrete and critical ways. Grappling with the overlaps and tensions will enable us to better situate these stories and what they can tell us across disciplines. I think the tensions among experience, knowledge, and expertise have really given way to resistance to stories that the plural of anecdote sort of represents. but we can sidestep some of these issues by parsing out sort of where the boundaries are between experience, knowledge, and expertise, and examining the strengths and limitations of each of the three. Finally, DIY FMT examples show that online patient stories can reveal the limits of care. And I would argue not just online patient stories, all patient stories can help us reveal the limits of care and help us understand what patients might bring with them to their healthcare experiences. In the same way that stigma stories provide context to the kinds of public understandings of illness and health experiences that patients might come to know as true, DIY FMT demonstrates that patients are eager, even desperate for interventions, and that patients often feel their needs are not being met through more traditional healthcare sources. These stories and the data they provide, these stories as data provide critical evidence for gaps in care that we should be paying attention to and might not otherwise see. Finally, I'd like to turn to some of my most recent research, which has been collaborative with Doctors Ben Trappe and Mike Aylward, both who are internal medicine docs at the University of Minnesota. Ben, Mike, and I started collaborating prior to the COVID-19 pandemic when they approached me interested in studying how and why physicians and other healthcare providers write and publish stories. Together, we began collecting and analyzing stories published in 4 primary medical journals: Journal of American Medical Association, or JAMA, the Annals of Internal Medicine, British Medical Journal, and the New England Journal of Medicine. Each of these 4 journals publishes a section in each issue devoted exclusively to the stories of physicians and physicians in training, and occasionally stories of other healthcare providers. The narratives themselves range in topic, but typically cover pressing issues affecting physicians. So it was no surprise that around April 2020, approximately 6 weeks after the World Health Organization first called COVID a pandemic, narratives discussing COVID began appearing. The study I'm drawing from today and the examples I'll show featured 70 narratives. I'm not gonna look at all 70, but that was the data set we were looking at, captured between April 2020 and April 2021 that significantly discussed COVID. This allowed us to capture a year-long snapshot of COVID narratives and experiences. And for this project, we conducted what I would describe as a rhetorical content analysis. So we built a code book to help track the rhetorical features and moves of these stories. So here's our codebook. Our rhetorical codebook included 3 main categories, as you see here: meaning-making themes, elements, and emotion. These codes were developed through several iterations of reading individually and collectively and discussing what we saw as rhetorically important or salient within and across the stories. For 2 of the categories, we also developed a guiding question you can see here to help us consistently apply the codes. For meaning-making themes, we were interested in what shaped the meaning of experience in this story. And for rhetorical elements, we were interested in what elements participated in that meaning-making, what forces or themes. For example, a story might have focused on communicating or grappling with uncertainty during the pandemic, particularly around uncertainty of getting PPE equipment, in which case we would have coded uncertainty as the theme and PPE as an element. Additionally, we coded elements we felt like the stories enacted and evoked in the audience, and we left this totally wide open. We coded it in C2 so we could compare our intuitive responses. This kind of rhetorical coding helped us parse the rhetorical or persuasive meaning-making dimensions in and across these stories. However, this kind of coding does not allow us to make generalizable claims, which is totally fine. We were interested in approaching these stories not as a snapshot into the lived experiences of providers throughout the first months of the pandemic, not to make sweeping claims about what all providers experienced or what the physician experience was like. Such claims would be arguably impossible. So let's take a look at some examples. First, many stories reflected an intense emotional and psychological transformation precipitated by COVID and treating in COVID that spilled beyond the practice of medicine. As one physician writes here, "The weeks since Boston temporarily beat back COVID have become more difficult than I ever expected. When I fall asleep, I'm haunted by memories of patients I cared for but never met. I hear their families' wails, expressions of gratitude, and most often, stunned silence. I can't remember their names, but I also can't forget their stories. COVID continues to live in my muscles. It permeates my marrow. How can we speak about transforming our system when we haven't yet reckoned with how COVID has transformed those of us on the front lines?" We noticed in this story how the writer expressed concern that their personal and professional life, the lives of patients, would be forever changed by living through and experiencing the pandemic. This excerpt also shares a complex sense of grief, fear, and uncertainty. So in this, we coded uncertainty, transformation of practice, and I believe also isolation. Second excerpt here demonstrates what we coded as visitor restrictions. This code, just for context, was applied to about 22% of the narratives we analyzed, second only to patient experience in that category. And concerns about visitor restrictions were discussed frequently by physician writers from diverse clinical and geographical contexts. Coded here too was a meaning-making theme of isolation, as the writer grappled with the impact of visitor restrictions and how they further transform this physician's practice of providing care. They write, "The visitation restrictions enacted to contain the spread of COVID-19 have vastly increased hospital isolation. More disturbing is that the absence of loved ones at the bedside means that our patients endure illness. As patients endure illness, there's no one beside them to ask questions, advocate for further testing, notice subtle changes in appetite or behavior, or insist that the problem that brought them to the hospital be solved before they're sent home. So these roles, noticing, advocating, accompanying, are my job now too. I must fill the gaps left by the absence of loved ones. And as in all aspects of my job, I am still learning." Authors frequently wrote about the abrupt transition from in-person clinic visits to telemedicine encounters. We saw this in 20% of our 70 stories. Several authors chafed against this change in the way that it negatively impacted the intimacy of the physician-patient relationship. To this story and many others like it discussed how valuable and sacred in-person interactions with patients are to the writing physicians. During more than 20 years of practicing medicine, I have worked on 2 different continents in a variety of medical systems and settings, but one thing has always remained constant: the practice of medicine as an in-person endeavor. Compared with face-to-face interactions, the virtual interactions seem barren, devoid of the richness the personal contact brings. And finally, we'll look at these last 2 examples. A number of small narratives mention discrimination and social oppression of minoritized communities that intersected in critical ways with COVID-related experiences. Around the same time frame of the stories we analyzed was the murder of George Floyd here in Minneapolis that spurred calls for racial injustice beyond and within medicine. Authors discussed the fact that COVID-19 was just the latest public health crisis that the American Black communities faced. 2 Black physicians wrote about their experiences at the intersection of the pandemic and systemic racism, noting the unique harm and discrimination that manifested throughout the pandemic's most intense months. In the first passage here, one medical student is recounting his excitement over being able to return to clinical medicine after his training was interrupted by the pandemic, but how this excitement quickly changed to fear and anxiety as he was forced to cross the country from his parents' home in the suburbs of Chicago to his medical school in Vermont as a Black man during the height of the civil unrest in summer 2020. He writes, "The intersecting crises in public health, the economy, and social justice feel intensely personal. And in the midst of the continued pain this pandemic has caused, I continue to be reminded that despite my hard work and education, I am more likely to be killed by a police officer than by the virus, just like any other Black man in this society." In the second excerpt here, another physician is writing from a rural Indigenous community in Nevada and explains the bias she saw in media coverage of COVID's impact on Indigenous communities, writing, "The national media reports on the severity of the Navajo Nation outbreak, reports on the severity and hits the usual notes of poverty, isolation, and lack of running water. These reports are factually accurate. The virus penetrated towns that utility companies have never managed to reach. But I yearn for stories that mention the diversity of talent and experience here, the resourcefulness. Outsiders seem surprised that the rural landscape hasn't protected us. I don't think the Navajo are surprised. From smallpox to H1N1 influenza, infections from the outside have always found their way here. It's just infrastructure that hasn't. It's not news." These examples compellingly articulate the deeply complicated systems in which healthcare providers were operating throughout the pandemic and continue to operate within, and the experiences with these symptoms that are made more real and perhaps more meaningful through storytelling. Collectively, these narratives offer a unique opportunity to examine the priorities, pressures, and issues that physicians face throughout the primary months of the pandemic. In addition to the significance of what is present in these narratives, what is not present also tells us valuable insights about the physician's experiences throughout the pandemic. We were surprised as a collaborative team to find that these narratives overall didn't reflect public discourse surrounding COVID-19 or what we were seeing most frequently in our media landscape. We anticipated more meaningful discussions about the political landscape of 2020, like policy decisions, mask mandates, shelter-in-place orders, and the intense surge of dis and misinformation. When commentary on broader public context like this was present, it was often really passing and discreet, mentioned so infrequently that it didn't emerge as an important code for us. Further, few professions have an outlet for recording the deeply personal thoughts, feelings, and experiences of their members during key moments in history. And we are fortunate that medicine has provided spaces for stories like those analyzed in this data set. However, Ben, Mike, and I would be remiss in neglecting to mention the privilege that physicians were granted compared to other workers deemed essential during the early days of the pandemic. This is reflected not only in terms of the economic and social privilege that some authors described in their stories as they made major life changes in order to protect themselves and their families, but it's also in the very existence of these reflective narratives. Few, if any, other essential workers had the opportunity or outlet to voice their fears, concerns, and struggles in such highly read and elite spaces. Nevertheless, we're grateful that as physicians recorded their individual stories, describing in sometimes great detail the uncertainty, fear, and isolation of the pandemic, as they wrestled with grief and sadness, and as they attempted to make sense of what it meant to practice medicine among unprecedented social change and human suffering, they also provided deep insight and an immutable record of the first year of the pandemic through the eyes of some of those whose work brought them closest to it. The themes, elements, and emotions, the rhetorical dimensions that make up these narratives illustrate the messy and at times painful process of transformation that medicine has undergone and continues to undergo. The rhetorical approach we took in reading and analyzing these narratives perhaps come closest among the examples maybe that I've provided to a narrative medicine approach. And indeed, my collaborators come to stories in and about medicine from a more narrative medicine background. However, our approach allowed us to look across multiple stories and track the themes and rhetorical dimensions of physicians and other providers' COVID stories over a span of time. Two, this empirical approach allowed us to more systematically analyze these stories and make more definitive claims about what physicians were writing and publishing about in the 4 journals we analyzed through the first year of the pandemic. There are undoubtedly limitations to the approach I'm showing here, and thus limitations to the kinds of claims we can draw from the data we collected and analyzed. However, these stories remain important and insightful. This approach also illustrates how physicians are using and valuing stories. Stories clearly matter to physicians in training and other healthcare providers, at least those who are reading and writing these stories, and evidenced by the fact that 4 major medical journals all publish them and have published them in some cases for decades. Whether or not this indicates the value of stories as data is maybe a separate question, but I think it does suggest we don't need to make a huge case that stories matter to most folks practicing medicine. These stories also suggest that stories have rhetorical value within the provider community, an interesting rhetorical value. So they have a certain rhetorical roles, such as they allow physicians and other writers to process lived experience, to grapple with difficult clinical experiences, to reflect on the complexities of patient care, to call for change in problematic systems and practices, and to learn from one another. And collaborating and talking with Ben and Mike, I feel like this last bullet is perhaps the most salient in their sense as people part of this discourse community. Really, people write and turn to these stories to learn and to understand how other writers and healthcare providers are grappling with what it means to be a provider. My goal in walking through these examples, all 3 sort of example sets, is to demonstrate how stories are indeed data. And they comprise many data points too, like insights into experiences, values, concerns, perspectives of storytellers. This is one of the key values of a rhetorical approach. Of course, the plural of anecdote is data, and I'd add that the plural of anecdote, when the data is generated through a rhetorical method, is empirical data. Rhetorical approaches enable us to conduct empirical research, that is, data collection and analyses that are based on observed and measured phenomena, and to build knowledge from those observed phenomena. This is the very work that a rhetorical approach to stories accomplishes. In fact, I'd argue that stories provide us one of the most empirical ways to conduct rhetorical research, and on the flip, rhetorical research provides an empirical way to study stories. Of course, I am not trying to suggest or say here that empirical research and data is the only kind of data that is compelling or valuable, or the only valuable way of thinking about stories, or that empirical research inherently makes research more transferable and portable across disciplines. But working on this talk and thinking through my recent research has helped me articulate what I would argue is the value of rhetorical work of stories, rhetorical studying of stories, and how I might talk about that value to diverse audiences who I think might benefit from the insights of an RHM. Additionally, rhetorical approaches allow us to place stories within larger networks of data and meaning. That is, we can put stories in context with other kinds of data produced by evidence-based medicine. in context with other stories, in context with clinical expertise and intuition of healthcare providers, in context with cultural, political, geographic space and time. Rhetorical research has the capacity to move from the micro-level dimensions of persuasive action within stories to these larger systems that shape and are shaped by stories. Ultimately, rhetoric as theory and method has much to offer the study of stories in and about health and medicine. As these examples hopefully demonstrate, there are many rhetorical dimensions to stories that rhetorical approaches allow us to see and engage that other approaches might not, including narrative regulation, public circulation, risks of stories, relationships and differences among experience, knowledge, and expertise, gaps in care. Finally, rhetorical approaches to stories can allow us to map rhetorical features at work in individual stories, as well as rhetorical features across collections of stories that help us understand the political and social implications of stories. This list, of course, is a starting place, and the work of many researchers and colleagues in the field of RHM and other allied disciplines can expand the capacity and are expanding the capacity of how we might rhetorically engage with stories in and about health and medicine. My goal here today is to spur thinking about the role and values of stories in research and how we articulate the role and values across different disciplines, value systems, and paradigms. Stories are a rich source of data that warrant continued attention by researchers trained in theories and methods that are commensurate with the study of stories, like RHM, the Rhetoric of Health and Medicine. Finally, I want to end by adding and highlighting that most of this talk has focused on how we can study and generate knowledge from and talk about stories in terms of research contexts and academic audiences. However, I think research into stories has an important, critical external value that alone makes stories worth studying. As researchers, we have a platform for paying attention and making visible that which might otherwise go unnoticed. Research into stories has the potential to be especially powerful in this amplification work, particularly when we're careful to listen to diverse stories. Even if our research doesn't transcend all disciplinary boundaries, the work of listening and thinking through folks' stories carefully does important work in the world, and I don't think that can be understated. Thank you so much for your time and attention today. It's been such a humbling privilege to be able to share my research and think through stories with you today, and I look forward to being in dialogue during Q&A.